This program is brought to you by Emory University.
Good morning, everyone. Hope you had a nice weekend. It is my pleasure to introduce Dr. Guillermo Escobar, who is an associate professor of surgery within the Division of Vascular Surgery and Endovascular Therapy. He's also the program director for Vascular Surgery Fellowship and Residency here at Emory. He joined us in 2017. He graduated from La Salle University Med School in Mexico City, did his general surgery internship at Mayo and residency at University of Colorado, where he was also a T32 research fellow and received a research award there in basic science. He's subsequently completed a vascular surgery fellowship at University of Michigan and stayed on as faculty there, and then moved to University of Arkansas for 4 years before joining us here at Emory. He has had several research and teaching awards. He has a passion for teaching. His interests are complex endovascular aortic surgery and aortic aneurysms, and he's well published in this area with several book chapters and many manuscripts, and I'm looking forward to hearing what he has to share with us this morning about mycotic aortic aneurysms.
Thank you very much. Yeah, you could throw a rock at the vascular division, you'd hit an aortic surgeon. So I join a rather busy group. So thank you very much for the invitation. I'm very honored to be part of the Cardiology, Heart and Vascular Grand Rounds. So I'm going to talk a little bit about mycotic aortic aneurysms, and it's a particular area of interest of mine for many reasons, the most important of which is we don't really have the perfect way to manage them, and when they show up, they tend to show up in the most unexpected, complex manner. I have no conflicts of interest. So the first characterization of the term mycotic was by William Osler in 1885, and during the Gustonian lectures, he talked about this concept of malignant endocarditis. And during these descriptive, as like most of the things in the 1800s and the 1900s, was very descriptive about autopsies. And he talked about the destructive vegetations that were on the inside of the valves in the aorta, and he called them mycotic for the first time. And at the time, these sort of micrococcus that they described inside presumably may be tuberculosis or syphilis, but it's really unclear because even in his discourse, he talked about the Grams with 2 M's. The Grams technique of stain was something new and something cool that you could see these micrococcus. And in the publication, he talks about this malignant or mycotic endocarditis. And that's the first time the term was used, even though it has nothing to do with fungus per se, they were fungating. So these mycotic aortic aneurysms are sort of divided into 2 big groups. One group is the true primary mycotic aortic aneurysm, and the second one is graft related, after a graft has been placed. And this is divided into 2 groups. One is the aortoenteric fistula, and I'm underlining it because I'll talk a little bit about what that is, and the aortic graft erosions. So these are infections of the graft secondary to an erosion. So for a primary aortic aneurysm, they're thought to follow a bacteremia of some sort and subsequent superinfection of either a diseased and irregular aortic surface. So if it comes from the actual bloodstream inside the lumen of the aorta, if you imagine this is an aorta and you have like a irregular plaque on the inside, you have bacteria that's inside the lumen, and it travels inside, seeds, starts to grow, and eventually starts to eat the wall. Alternatively, there's another theory that it's microembolization from the aortic into the aortic wall via the vasa vasorum. So in the same model, you have the vasa vasorum is actually the source, and that's how it gets outside from the adventitia. And little by little, as it eats through, it starts to form essentially a pseudoaneurysm, which is contained within fibrous tissue. So these aneurysms are rather unstable because they've eaten through the wall. They're actual holes when you go to operate on them. And in some cases, it can also be from extravascular infection. For example, infections of the osteomyelitis or of the spine or of the kidney or the ureter, and they can eventually eat backwards and go from outside in. So an aortic graft erosion and fistula are 2 different things that are sometimes interchanged erroneously. An aortoenteric fistula communicates 2 cavities. So for an aortoduodenal or aortoesophageal fistula, there has to be blood shooting into the lumen. So this is a pretty dramatic case of an aortoenteric fistula where you can see the contrast shooting into the intestine. Here's an endoscopy where you can see the graft material eroding with blood around it. That is an aortoenteric fistula, as opposed to aortic graft erosions, or when the actual graft rubs through the intestine or whatever, but there's no blood. There's every endoscopist has a list of these great pictures where they go inside and see the graft, all the way through. But notice there's no blood. That is just a aortic erosion, if you will, graft erosion. So now that we have that out of the way, the idea is that the rigid grafts eventually sort of rub their way through the softer structures. They can go through the intestine, they can go through the ureters, or there's some other crazy descriptors of things that they've eroded through. But if it's the actual edge of the graft with the aorta that erodes, that's how you get a fistula. Generally speaking, the grafts don't fall apart. Nothing really eats through them very effectively. And they get this concept of the herald bleed, where they'll have one hematemesis of some sort, and then that'll be followed by the actual, lethal, life-threatening one. So I'm going to focus only on primary mycotic aortic aneurysms and move a little bit away from the grafts, because the graft just can be a talk in and of itself. So when we talk about the etiology, it's often associated with endocarditis. And for all of you who do your rotations in the inpatient service, at some point you may get someone with endocarditis that subsequently has some sort of aneurysm. Or it could be from an infected central intravascular procedure implant. Obviously, valves are one of them. They can also be central lines with paradoxical emboli. And basically any source of bacteremia or pyelonephritis, UTI, perforated viscus, anything can really cause it, anything that causes bacteremia. However, the source of the septic embolism can be pretty innocuous and even iatrogenic despite no apparent complication. Things like dental work or even brushing teeth. Typically, the first thing I look for is I have them open their mouth and look at their teeth, because silly things like brushing their teeth or minor trauma can cause it. Colonoscopies, visceral biopsies. I have a patient that I'll share with you who had a BCG treatment for transitional bladder cancer. Intraarterial procedures, patients that have catheterizations, have stents, they get infected, or just the delivery with contaminated materials. Again, as I mentioned previously, you can also have infection or perforation of structures next to it, like the esophagus. The old fishbone in the esophagus causes an abscess. Abscess leads to infection. Next thing you know, you have an aortic infection. Spine, ureter, prosthetics. And eventually you get, in some cases, even with patients that have dissections or aneurysms, and the aneurysm literally, despite it not being a graft, can potentially erode through structures. And I've seen a few weird ones that I didn't even know existed until the first one I saw, but even aortoesophageal fistulas can occur from aneurysms. As far as primary mycotic aortic aneurysms, they're really relatively rare. Most series that look at big series of aortic repairs, they'll find about 1% or less of all aortic aneurysms that are actually repaired, and maybe about 2% of all aneurysms out there. They tend to be saccular, kind of like I did in the diagram, and they tend to be multifocal. You'll tend to see like punched out areas of different blood vessels, sometimes visceral vessels. And historically, the most common etiology was from syphilis. Currently, there's an interesting split between the East and the West. In the East, Salmonella subspecies, generally not typhoid, are more prevalent in the East, whereas Staphylococcus aureus tends to be the most reported in the West. However, some series will have strep pyogenes or strep pneumoniae in the top 3 for sure. And there's at least one series from the Mayo Clinic where it has E. coli in the top 3, which is sort of odd, but they do get people from all over the world. Rarely other etiologies have been reported, and I mentioned a couple, but Haemophilus influenza, brucellosis, I'll share a case that I just did recently of that. BCG, Listeria, Candida, other things can potentially cause it. With regards to the distribution, the majority tend to be infrarenal, and that accounts for about 50 to 60% of all the cases. From a surgical perspective, when they're juxtarenal, they add additional complexity because you have to probably revascularize the renal arteries, because when it eats up close to the renals, you can't use that part of the aorta anymore. And then about a third will take place in the thoracic aorta. The upper part of the thoracic aorta is probably the simplest, if you will, as long as it's away from the arch. And the lower part ends up being a thoracoabdominal because it tends to get close to the visceral vessels. And the remaining is this sort of group around the visceral vessels, which are by far the most complex and thankfully the least common. So how do they present? as you can imagine. They have a sepsis syndrome, kind of like you guys see with endocarditis, but sometimes it's from a less than obvious source. So while they have fever, malaise, chills, loss of weight, positive blood cultures that nobody can figure out what it is, a lot of them get misdiagnosed for a long period of time. And a lot of these infections tend to be indolent, particularly some of the odd ones like the Mycobacterium or brucellosis. A lot of them will present as back pain that just will not go away. And these patients eventually end up with an MRI, and the MRI is the one that diagnoses. It's like, they may have some osteomyelitis even at that time. Here's a case that we did recently, and I like to highlight this area right here, and you can see that there's a destruction of the bone. So whether or not this was a primary infection of the spine that moved forward or from the forward moving backwards, but it's common that you'll see this posterior punched out area. And then here you can see really clearly where the sort of the aneurysmal portion of the aorta as it goes backwards. And then you'll notice this low density section right here where the abscess is inside. Some patients will have abdominal pain, depending on where the inflammation is the worst. And some of them will present with either embolic complications and of course hemorrhagic shock, either from rupture, intra-abdominal retroperitoneal rupture or fistula, as we mentioned earlier. So how do you treat them? Well, it's pretty obvious, right? They're an infection. So you just give them antibiotics, big deal. But is this enough? Unlike other places, if you remember, it eats away through the wall. So for the medical management, in series that have looked at medical management only, either because surgical preference that the patient won't survive, or patient preference that they say, no, thank you, I don't want you to cut me in half, the hospital mortality is at best 36%, but it's as high as 82%. And we all know that hospital mortality just means right before you get them out the door, but that doesn't mean they survive. And a series of so-called high-risk selected patients had a 50% in-hospital mortality, but the rest of those that actually made it out died within 2 weeks. So the aneurysm-related mortality is at least 3/4, and the grand majority tend to die within a few months, just with antibiotics. And there's a trend towards this concept that gram-negative organisms tend to be a little bit more virulent. So essentially, it's a lethal condition if you don't treat it. Antibiotics just won't cut it. So if good is not enough, is there anything better? Well, surgical approaches are better. And just like everywhere else, if you have a horrible infection, remove the infected tissue is probably better than just leaving it there. But then the problem is, what do you replace it with? If you put a prosthetic in an infected field, it will get infected. And you can't just tie off the aorta. We tried doing that in the 1920s and 1930s. So if we replace it, is there a way to lower this morbidity? And particularly the majority of these patients tend to be older as they have atherosclerotic aortas, although you do get some young patients. So the original true aortic surgery outside of ligating a vessel was using cadaveric grafts. And the use of cadaveric grafts date back to 1903, where a cadaveric graft was used to replace a carotid. And the first use in aorta was for a coarctation by Gross in 1948. And the first use for an abdominal was by Dubost, who advanced a lot of cardiovascular surgery in 1952. And to this day, we still use, now we use cryopreserve, kind of like cryopreserve valves. We use cryopreserve aortas. Here's a case we did with cryo aorta. And we ligate the little lumbar branches, which actually can be quite pesky because they can blow out and bleed. And a very, what's the right word? An advocate for the use of cryo vessels is Dr. Vaught. And he's made multiple publications talking about how great cryopreserved allograft is versus everything else. And there's a nice little comparison he did in a hospital comparing prosthetic, both AXFEM and other prosthetics versus the use of cryo. And basically he showed lower mortality, lower operation length, avoiding reinfection, 91% no reinfection with cadaveric. So cadaveric grafts are actually quite popular and they're very strong proponents. UCLA is another one that loves to use cadaverics. But an interesting group in Norfolk, UK said, wait, if you use cadaveric, they're like $15,000. And if you use a prosthetic, they're terrible. So what if we made our own grafts out of a xenograft using a bovine patch? We use bovine patches a lot to sort of patch things. So they rolled up one of these xenosures in 6 patients and they made their own tubes. And they showed multiple cases of mycotic aneurysms. 6. And this is what it looks like. On the left is their handmade tubes sewn together, and they basically recreated their own with the idea that it was a good technique. And in their 6 cases, in their series in Annals of Vascular Surgery, they kept them on antibiotics after, 30-day mortality of 0, 13-month reinfection rate of 0, and 100% survival. All 6 are alive at an average of a year. I'm going to stop here and just tell you this is the only series that exists like this, so I don't know what to make of it, but certainly it's a definite option. I'll leave it at that. So what if you want to use just a regular old graft? I need to replace this aorta. Why not open a box and get some good old Dacron thanks to the Bakey? So the problem is that it's just going to get reinfected. And in multiple cases of emergency cases, it's very well documented that putting one of these in, you're going to have a higher reinfection rate if you just do that. So recognizing this in the 1980s, there was a lot of effort to try to figure out what you could do to soak the graft in. And one of the particular antibiotics that seemed to impregnate the best in the gelatin weave and in the pre-clotting that we used to do, we'd get the grafts that was polyester. And so you wouldn't, sort of pump blood through the fibers of the polyester. They'd roll it in the patient's blood so it would form this little film of clot. And subsequently, they would put it in rifampin. And the concentration that seems to be the best, both in vivo in dog and animal models and in vitro, is the 60 milligrams per milliliter. And they found it to be 100% resistant to Staph aureus at 7 days and about 80 to 90% at 10 days. So it seems as though the rifampin really soaks into the graft and sits there and gives you a few days of protection. And subsequently, hopefully your systemic antibiotics would kick in. And it's pretty popular. Pretty much most people in most cases where they know they're mycotic will tend to soak it in rifampin. I will say that the majority of people don't actually use the 60 milligram. They sort of shake some in there and soak it around. But when you do it, it looks like this. It looks orange. And when you put it in, here's a sort of a nice drawing from the Mayo Clinic, where you can see it sort of stuck in there. That's for an aortoduodenal. And also an additional protection. So now you have the graft and it's sitting in the infected bed. You wrap it with some momentum and try to isolate the graft. And this is by far a very optimistic drawing for the Mayo Clinic. It's rare that you can get that much momentum, and it certainly never wraps it quite that perfectly, but I definitely always try to use it. So Claggett is a surgeon. He's retired now from UT Southwestern, and he thought the whole idea of using prosthetic was dumb. Because number one, a lot of these patients, when you take out an infected graft and put another one in there, it tends to either clot off or it tends to get reinfected. And he found that a literature review showed that about half the patients are patent at 3 years. So if you were going to replace something, you should replace it with something better than what you took out. And he described the idea of making a neo-aortoiliac system. And what he did is that he made long incisions in the thighs and took out the femoral vein, or the so-called superficial femoral vein that runs parallel to the superficial femoral artery. And with these long incisions and surgeries, you dig out the 2 veins. And in 1993, he published a series of the so-called NACE. And there's different variations of how to create it, depending on how much length you have, et cetera. But basically, this is what it looks like. This is the case I did on the left side with a NACE reconstruction. The problem with the NACE procedure is that while it sounds good, you're using autologous, it's endothelialized, it's all natural, but it takes a long time to do. It's affectionately referred to as the vascular Whipple. You have to harvest the vein, usually in both legs. You then have to open the abdomen, remove the infected portion. You have to sew the vein together, and then you have to replace the whole aorta. And the problem with that, if you take someone's femoral vein, they'll have variable degrees of swelling, and some of them can even develop compartment syndrome, partly because it just takes so long to make. When you clamp the aorta and start working on it, digging out the infection and creating the graft and sewing it and tunneling it, patients get compartment syndrome when you return flow. However, it does have excellent patency, and it has a limited risk of infection. There are a few cases of blowout, sewing a vein tenuously to an aorta, and then the patient's blood pressure goes up. But that is arguably a problem with other techniques as well. And it may be the best, maybe for young patients for longer patency. And I would argue that they're also for young surgeons because it takes a severe amount of energy to do. One of my old partners at University of Arkansas was probably a modern master of this. He learned under Claggett and then became a big advocate. And he wrote a paper saying that if you take the veins and prepare them and do the incisions and dissect the vein out, but then leave it there, take a break and come back the next day, and then do the reconstruction and breaking it up into 2 days, you have the same outcomes, but it's easier on the surgical team. So what if you don't want to leave anything? The whole idea of digging out veins sounds terrible. You don't want to leave a prosthetic and xenografts, and that just sounds crazy. Just get rid of it. Well, then what you do is the so-called extra anatomic bypasses. When we talk about that is because we're doing a bypass in a route that surgeons made up. So the classic is that idea is that you reroute the blood to the legs and then just remove the entire infected aorta from the middle. And the most common is the axillofemoral bypass. And we do quite a few of these here. This is several of the Emory faculty love to do this over other techniques. And it's basically 2 stages. First, you do an axillary artery to the femoral bypass, as you see there. Then, either in the same setting or the next day, you go back and then you remove the infected material and ligate the aorta. And despite separating it into 2 days, you don't generally, there's no perception of increased risk of graft infection. And the nice thing about extra anatomic is you can get pretty creative. And I would be remiss to not quote my father and mother's paper from 1973 of the ascending aorta to both femoral arteries. And they did this out of desperation in a patient that had, it was actually a medical student that had recurrent UTIs and had an infection that actually blew out their iliac artery. And they replaced it with a graft and subsequently developed a aortovesicular fistula and was bleeding to death. And in hemorrhagic shock, they found that the axillary arteries in the young person was too small. So the only other good option was to take it from the aorta. So they did an ascending to bilateral femoral. And I love looking at this because it just seems so crazy. And I don't think I've ever seen anything. There's no second case to my knowledge. So what about thoracic aortic? Well, the things to think about a mycotic thoracic aortic aneurysm is, does it involve the arch? Because in those cases, you have to do hypothermic arrest, which again adds to the complexity, adds to the morbidity and potential mortality. Is there an actual fistula? A lot of the thoracic aortic aneurysms may involve the esophagus or the bronchus. And of course, the outcome's even worse if you add other things. If the reason that fistula is there is because of cancer or a perforated esophagus, if they're actually bleeding, like the case I'm going to show you in a minute, or these patients that are very aged. Or the opposite, is it all the way down to the bottom? Does it involve the thoracoabdominal vessels? If you do have to replace it, what are you going to replace it with? Are you going to have an increased risk of spinal cord ischemia? There's so many things to think about with the thoracic as opposed to the infrarenal. So thankfully, they're not as common, but they still account for 1/3 of the cases. When you think about open repair, the majority of series will talk about an aneurysm-related mortality of up to 50% in the thorax. The largest open series by Sue in 25 patients, again, relatively small. 13 involved the arch. All the patients that were treated medically only died. 57% of those died in the hospital. The in-hospital mortality in this particular group was amazingly low at 12%. But the aneurysm-related mortality, we're crawling back up to that 20% that we'll talk about in the future. So 28% in the surgery group. And the late graft reinfection rate, again, in those that survive, was 16%. So if you can make it out of the hospital, generally you do okay. I'd like to talk a little bit about the Ballard technique. Ballard was a vascular surgeon who wanted a way to perfuse the intestines while repairing traditionally a type 4 or a type 3 thoraco, but he didn't want to use extracorporeal pumps. And what he did is that if you have this aneurysm there, but the thoracic aorta is actually okay at the top, is first he'd do a graft from the normal good aorta, and he'd do bypasses to the visceral and the renal arteries. Then he'd replace the middle and reconnect the right kidney. And Dr. Faubert, who I think logged in, I don't know if she's still here, here she's doing one with me, and you hand sew the little branches on there so you have your graft ready to go. And in the case that we did it, you can see this patient has 2 blobs, one on the back, right with the renals, right above the renals, near the SMA, and then has another one at the bottom. So these multifocal aneurysms. This patient ended up having brucellosis, which we didn't expect. He had fevers, chills. We couldn't get anything to grow. And here's the reconstruction. You can see this little octopus at the top. Here's the main trunk. Here's the little branches. And then here's the lower, the straight part. And this part is the normal aorta where it's all coming off of. And the 3D reconstruction looks like this. So this patient, thankfully, I used rifampin because brucellosis is treated with rifampin. So I got lucky there. But in general, I like to use this Ballard for patients. So I feel like connecting an extracorporeal pump and using a sump sucker and stuff that I might increase septicemia, and I don't know. The other thing is that I can isolate the grafts from the infection. So I am able to perfuse the visceral vessels. And then when I clamp, the intestines and the kidney are happy, and then I can dig out all the infection that I need to do without worrying too much about the graft. In a case, I had a patient, same thing, fevers, white count, wouldn't grow anything. And 3 weeks later, came back with a positive BCG. And you can see the multifocal, sort of the posterior thing. I think he had back pain originally and abdominal pain with the infection in the front. And he also had visceral artery aneurysms as well. In this patient, I did a sort of a modified Ballard where I did aorto visceral bypass from the top. And then I dug out all the infection and all the pus that he had in there, which again amazed me that nothing grew back until later. But it's a modification of the Ballard. So in a series from the Mayo Clinic of 43 patients treated with open repair, this is for abdominal and thoracoabdominal, actually and thoracic, their operative mortality again was this magic 20%. And when they compared to a general population at the very top and non-infected AAA repairs, clearly it had a lower survival. So it had a 50% mortality at 5 years. The average length of stay was 25, but notice it was almost 6 months in the hospital in some cases. Late deaths were mostly cardiovascular in their series. About 40% of patients had stroke or MI, and cancer in 22, which gets back to this concept of why did they have the infection? A lot of times cancer or radiation or erosions will occur. And graft-related complications were relatively low. And interestingly, they compared graft-related complications at 5 years. And what they found is that it was very similar to patients with infection, without infection. So the idea is that if you make it out of the hospital, generally speaking, you're going to do well. The problem is, of course, that huge drop of 20% at the very beginning. A similar series of 56 patients, this reference is wrong. A similar series of 56 patients from Taiwan, from the same group that I mentioned earlier. They had a hospital mortality of 23%, very consistent. Average length of stay was significantly longer, 20 days at the Mayo Clinic, but 45 in Taiwan. And most of the deaths after discharge were from reinfections. So of the 4 people that died, the 4 people with reinfection, they all died. And late surgical related complications were relatively low. Once again, if you make it out, you generally make it out. And they were similar to the early ones. So early and late were about 16 and 18%. Their 1-year survival was 82% for the infrarenals, but only 50% for the thoracic. So as best we can tell, we've got a perioperative mortality of about 20% if you do this open, and 50% if it's abdominal, maybe a year if it's thoracic. So all of you are probably thinking, all this open stuff sounds terrible, right? We're cutting people in half, we're doing this. Isn't there any other option? I mean, this cannot be the only way we fix this. So while it's true, open surgery is not perfect, but it has this high morbidity, mortality. It's definitely higher in thoracic and thoracoabdominals. And you have these sick, old, infected patients, right? They've been not eating, they're not drinking, they're doing, they feel ill. They're gonna do badly if we start doing aortic operations on them. So everybody knows that endografts are generally better. They have lower morbidity, mortality in all cases. Well, let's think about it. So the first description of using endo for mycotic aneurysms was by Semba in '98. And they had 0% mortality at 30 days in all 3 patients. So once again, amazing. Patel used TVAR in 14 cases of infected thoracic aorta, 86% early survival, and 58 at 3 years. of which a quarter had reinfections. And there's a review that includes 48 patients, and it had a 10% 30-day mortality. This is sounding really good, but these are case series. They might be a little bit biased. So why wouldn't you use an endograft? Well, if you really think about it, if you put a prosthetic into an infected aorta, so remember that drawing with a punched out hole. If you just put something in there, it's going to immediately get infected, right? And if you don't remove the infected aorta, you're basically forming an abscess outside of the endograft. So you really have to immediately repair or exclude whatever the hole is. So if you had a case with like an aortoduodenal fistula, an aortoesophageal fistula, sure, you can plug it up with an endograft, but realistically, if that hole stays there, you're not fixing anything. So here's a case of one of my partners when I was at Michigan, and they saw this and they said, wow, that's a beautiful, just a penetrating aortic ulcer, big deal, put a TVAR in it. Put a TVAR in it, and then all of my partners went to a meeting, and I was a junior partner, and I was left alone. And you know what happens when you leave the kids alone? So he comes back, little TVAR there, and 2 weeks later comes back with fevers and now pain in the abdomen and the back. So this was his cut on his original day 0, 5.5 centimeter aneurysm. And within 2 weeks, it's now 8.7. So clearly this abscess has formed and is chewing up his aorta. But now it's a thoracoabdominal aorta. And I ended up doing this creative, the aorta was too big for a regular graft. I didn't want to put a prosthetic, wanted to use a cryo. So with a friendly cardiac surgeon who I really liked, we used to partner up and do crazy cases. I ended up sewing 2 arches because that's all we had in the fridge in Michigan. And we recreated the aorta, and then I did an aortoceliac bypass or aortohepatic bypass. So clearly just putting an endograft is not a good idea, right? So it just sounds like something that nobody should be doing. So typically one thinks of an endovascular management of a mycotic aorta or a fistula really is temporizing. You're going to plug up the hole, catch your breath, and maybe come back later. But some interesting combinations have been evolving. And if you look at endovascular only outcomes, there's a series that shows the 1 month, 6 month, 1 year, and 5-year freedom from all-cause mortality is way better than what we were talking about earlier. The 5-year 50% is sounding pretty comparable, only without all the morbidity. The best outcome in all of those without documented infection after treatment is 84% survival at 4 years. Now, the problem is that all of these are little case series. So is there bias? Is there recall? Did they miss some cases? Or did they do it in cases that maybe were adequately treated with the antibiotics before? We don't really know. But there is definitely a 20% recurrent infection rate. And there's a higher mortality in other series. But I'm giving you sort of the best possible view. So if you look at this, pretty optimistic, right? 50%, 50 months, 50%. That's way better than what we were talking about earlier. So if you're not supposed to do this, what do you do in a case where either the patient is too high risk or you just simply can't get in? Can you just use endografts? So I had a patient when I was in my first couple of years who was a 44-year-old IV drug user, had Staph aureus endocarditis after a previous repair of a valve, had bacteremia, had a previous aortofemoral bypass, which was occluded, had a bunch of stents and a bunch of laparotomies. She had multiple bowel obstructions and ultimately had a ileostomy and just her abdomen had, I think it had like 6, 7 operations. Had a CT scan and Indian nuclear scan that was positive for a 2 centimeter mycotic aneurysm. And you can see it just right here. At the very bottom of the bifurcation, there's a little blob. And I said, great, 2 centimeter, positive endocarditis, CT surgeon, tell you what, if you do her redo, I'll check her out later. I kind of thought they weren't going to do it, but of course they did fix it. So in 10 days, despite antibiotics with MSSA, the terminal aorta, as you can see, just totally blew out. So clearly, you got to fix it. So with one of my senior partners, for hours, we tried to re-enter the abdomen. 5 hours later, we'd already dug up the femoral vein, we can do reconstruction. We couldn't get to the aorta. So I decided to do an endograft, but I added rifampin to it. And I did a fem-fem, and I landed it low just in case it got infected. Maybe I could go back in. And you can see the gas, and you can see the way it looks with the fluid around it, where the endograft was. But I followed her for a year with only IV antibiotics. And amazingly, if you look at the distance between the graft and that stent, it totally sunk down and went away. And all I did was add rifampin to the endograft. So I basically used the same principle that we talked about before for open in the 80s, and I just injected it into the sheath. And I published this with another case that I'll tell you in a second. And you basically inject it in the sheath. You can do it this way for this particular Medtronic graft and the other way for the Cook graft. But what about aortoenteric fistulas? Well, this patient showed up and she had a full-blown hemorrhagic shock, previous Dacron batch, and had an aortoduodenal fistula. You can see the little, the bleeding forward. Notice this shriveled up kidney on the left side. Had no iliac arteries, no way to get in from the iliacs. And this is what her abdomen looked like. Multiple hernias, multiple intestinal resections, and had actually a skin graft on the intestine. You could see the intestine moving under the skin. There was no way we were going back through the abdomen to do all that. Not while she's bleeding to death. So an endograft was really the only option. And I'd done it already once before. And I won't tell you exactly how I did it. It seems magical how I got into her abdomen, but it actually wasn't. It took a ton of work. And we did a little graft off of the occluded renal artery. And anyway, we stuffed the graft in, covered the hole. She stopped bleeding. And I then started talking to all the general surgeons about going back in there to dig out the duodenum and try to fix this. And all of them said, no way, she's too high risk. She's gonna die anyway, who cares? So I put her on TPN and I watched her forever. And she kept coming back. And this is her in clinic, just wandering. She quit smoking, she started losing weight. She looked better and better. She came back. And how'd she do? I'll tell you in a minute. She did well enough for publication. Aortoesophageal fistula, 69-year-old male, hemorrhagic shock. Notice the contrast layering in the duodenum. And the animation's a little messed up, but there's a fistula pouring into the duodenum, up and down from a dissection, spontaneous. Coming in a second. So this patient, we took him to the operating room. And to cover stop the bleeding, he was actively bleeding up and down into the esophagus. We put a TVAR, here's the dissection flap, we sealed it up, and the idea was to just temporize it and fix him later. We then did a cervical esophagostomy, we diverted his esophagus out his neck, and he went home. And the plan was, we're gonna get him better, and then we're gonna come back later and fix him. Well, he had different plans. He came back within a few days of discharge with fever, malaise, and you could see the fluid around the graft, a little bit of gas, could be from the graft, I don't know. Either way, he was not looking good. So we took him to the operating room and did a rifampin-soaked Dacron esophageal resection. And then we raised the stomach up, we being the thoracic surgeon, and then put him back together again. And he actually went home, had some mild vocal cord weakness and did really, really well. And he's a really funny story I can tell you later. But the problem is, as high five as all these sound, if you just use an endograft, if you follow them long enough, they tend to do this. They come back. And usually they come back to you because no one else wants to touch them. So what happened in the woman is 1.5 years later, she formed a massive retroperitoneal abscess that actually compressed her femoral nerve and she couldn't walk. But she was in way better shape. When she showed up, she was in hemorrhagic shock. Now, she quit smoking, lost weight, she started getting physically fit. And despite not having iliac arteries, she was able to do stuff. So I did an axillofemoral and an open resection with one of the senior general surgeons that I came up with and said, well, she's back 1.5 years later, let's do it now. So sometimes using endografts is good to get you out of trouble, but even with the rifampin, even with whatever you want to talk, they're probably going to come back at some point. So can you use endovascular for thoracoabdominal? You can, but you have to be endocreative. And there's a nice series by Silverberg, but here's a case that I did with a sort of large, massive, disgusting mycotic thoracoabdominal. And thankfully, with good antibiotics and a good seal, we were able to get it down. And you can see how it shrunk down at the level of the viscerals. So after that 1 or 2 years, it seems that most of the recurrences are going to happen. If you get away with it, you're in good shape. If you make it to 2 years with your endograft, chances are they're going to survive and they're going to be okay. And in general, they're probably going to do better than open if you just put everybody together. But if you only do endo for the very, very sick, chances are they're not going to work. And you sort of look at the survival, that you get a huge drop in the patients that are going to die in the very beginning. And then after that, they sort of linger for a year or two. So if you look at this, you say, well, what else could we do? And there's been a lot of interest in revisiting old data, like everything. My old basic science research mentor said, there's no such thing as original thought. That's why they call it research. So draining the abscess after you put the endograft. So as far back as the 1990s, there was a lot of interest of draining abscesses or infected grafts. So patients would have an aorta bifemoral, it would get infected. And if you couldn't, wouldn't, shouldn't go back, Belair started doing drains and putting drains around the aortic sac. And there's a literature review that found 29 patients with infected endografts. So somebody had a TVAR or an EVAR, it got infected. And the hospital mortality was very similar to what we've talked about, 21%, and a bunch more died within a year. So draining them alone, it's not very good. It's 50% at a year. Of those, 41% only got antibiotics and the rest of them had their drain. The mortality, again, 50%. With drain, without a drain, doesn't matter. It was worse if they had a fistula, it was worse if they had cancer. Fine. So putting a drain doesn't seem to work. But what if you added antibiotics and actually washed out the sac? So a nice theory was established in 1994 by Morris. And he collected 10 patients with aortic graft. This is open, aortofemoral stuff. And he not only just put it in there, but he would wash it out with gentamicin, penicillin, and metronidazole. And they would either do a small incision and sort of stick a bunch of drains and penroses in there. And then of course later we do this now percutaneously. But they basically irrigated, and it was really funny because in the publication it says, I have no idea how long. But he basically just sort of washed it until it became sterile. And of those, only 2 of them were known to reinfect. So in the 10 patients, 80% had a 1 year, sorry about that. Where's autocorrect when you need it? Survival. And there's a recent publication by Akhtar with VRE, and they had a drain placed in the aortic sac. They irrigated it with linezolid for 28 days. And at 7 months on the CT scan, the fluid seemed to disappear. So this idea of draining and adding antibiotics is something that's become a little bit more appealing if you're going to use an endograft. So I've done a few of those for high risk, that's supposed to be a quote, for high risk cases. But I want you to know that when I came to Emory, and the first time I called the radiologist as, hi, I know I'm new here, but I would like you to stick a drain into somebody's aortic sac after I put an EVAR or TVAR in this really high risk patient. And if you want to know what's harder than make pigs fly, is to try to make a body radiologist purposely stick a needle into the aorta. It took a bunch of convincing. I had to send them a bunch of papers, beg, plead, sign a paper that if we get sued, it's on me. But ultimately we did it. And this is what happened. The white blood cell count in the patient dropped like a rock after we did it. And I started lavaging her. I can't remember what the mixture of antibiotics was, but excuse me, it was a patient male. And I lavaged him for several days and he left for rehab. And sadly enough, he died a week later of unclear reasons, which was very disappointing. So the idea that placing a prosthetic in an infected aorta immediately gets infected, probably not. Not removing the infected aorta will cause an abscess, maybe not every time. And do you have to immediately remove it out for aortoenteric fistulas? It's probably eventually it's going to get an abscess, and probably you have to do something for aortoenteric. But these aren't absolutes. So in conclusion, here we go. Mycotic aortic aneurysms are rare, but deadly. Look for what I like to refer to as FLA, which is the funny looking aorta. If you get a CT scan and you have this sort of lumpy circles sort of appearing randomly sparsed out, sure, it could be just a random aortic ulcer, but it could be something else. or a patient that has bacteremia that just won't go away, and you get consulted for this, TEE, but nothing else happens. Get a CTA. You never know. You might find some weird mycotic aneurysm somewhere. Unlike graft erosions, primary infections grow very quickly because they're literally pseudoaneurysms. The bacteria just eats through the wall, so they grow rather fast. Open repair is better than conservative management, but it still has a high mortality. 1 in 5 die within their hospitalization. And most of them will have some degree of morbidity. They'll have renal failure, they'll have respiratory failure, etc. So with all those different approaches, as you know, it's sort of like managing hypertension. The fact that you have 50 different ways of doing it means that there isn't one that's perfect. But if you try to tailor the correct approach to one or the other, sometimes you can hedge your bet in one direction better than the other. Endografts and mycotic aneurysms save lives. Patients that show up unstable, get an endograft in them, you can at least temporize it or at least control the bleeding until everybody catches their breath. I use them liberally for bad cases. Either the patient is a poor surgical risk, the aorta is terrible, it's in a really bad place, or just the patient is presenting in an unstable manner and there's not much to do. Ideally, treat them with antibiotics as long as possible before you implant. If you have the opportunity to treat them with antibiotics for a few days or a few weeks, feed them, make them feel better, they're going to do better regardless. And this may be voodoo, but adding rifampin to Dacron endografts may prolong their protection. And I have at least 2 cases published more than a year, and I have several others over a year. And unfortunately, as you've heard, I've changed jobs too much, so I don't have more than 3 years experience in any one institution, but I really would love to collect all the cases I've done. You just put it in. And if you do it, I will immediately say, of course, that was a brilliant idea. Well done. Put that rifampin in that endograft. I've also added translumbar or transthoracic pigtail drains, and I've done lavages with rifampin if they're gram-positives, and if they're gram-negatives. I've used gentamicin in the endograft sac, and in general, I've done it for 10 days. And again, this may or may not be voodoo. TPN for the aortoenteric fistula worked for me on that patient with the aortoenteric fistula. Maybe it's voodoo, but maybe having Rice Krispies brush across your endograft is a bad idea. And I like to use antibiotics for life. Some people say 1 month, some people say 3 months. The whole idea of having to go back in there is not something I look forward to. So I either put them on low-dose Augmentin or Bactrim, and then plus minus diflucan. If they have the aortoenteric fistula, then I add diflucan. And the reality is that you have to have a good plan B, because they may come back in 2 weeks, or they may come back in 2 years. So I like to deploy my endografts low, cut off the suprarenal fixation, whatever it is to make them easier to take out. And with that, I end, and happy Monday. I'll take any questions.
Guillermo, thank you so much. That was simply outstanding. And I know we all learned a lot. It just goes to show just how much creativity it takes for just because no 2 cases are similar. So I really appreciate you giving this talk to us. While we're waiting for questions, I guess I'll start off with one. So some of these patients who, as a cardiologist, when we've had patients who've had repairs and things, I just have them follow with vascular surgery. And I never quite know when, how often to do the scans. Is it every 6 months?
Right.
Is it every year? Like once they're repaired, how often, what is your preference?
So typically what I'll do is that I'll do 1 scan at a month just to make sure there isn't an obvious, reaccumulation. Typically that first scan is a little bit dicey because you'll see some fluid around the neck and things like that, around the anastomosis and stuff. But what I want to look for is gas, or I want to see like an expansion at that 1 month. If they look good then I'll see them at 3 months. And if they look good there, I'll see them at 6 months. And then after that, yearly. The problem is that if you read this data, you know that somewhere between 10 to 20% will reinfect. So I like to catch that early as possible, because theoretically I could drain it or something to that effect. I also wrap omentum around it, so it'll have like a black cover. And if that black cover isn't black and it starts to fill up, black is in low density of fat, then I'd like to catch it early. But There is no specific, but I'm pretty aggressive with the 1 month, the 3 month, the 6 month, and then if they do well, I go for a year. Why the abdominal aorta? That's kind of interesting. So I think that tends to be where there's a lot more plaque. Typically, the thoracic aorta tends to be smoother and has less plaque, and maybe the abdominal aorta has more. Some people say that the abdominal aorta has less vasculature, which is one of the reasons that it theoretically forms aneurysm more. So maybe it has less immune system. I don't know, but that's the best I got.
Any differences between men and women in terms of how well they do?
It tends to be more in men as far as incidence. As far as, I think all these series are too small to compare men to women. I've never actually seen that outcome. Generally speaking, when it comes to vascular surgery, women tend to do poorly in pretty much every metric. But I don't think there's a series big enough to answer that question.
Any other questions, comments? The question of lifetime or lifelong sort of antibiotics. What do your ID colleagues think about that?
They're pretty lax. I do sometimes hear it's like, oh, Dr. So-and-so said, I can come off of antibiotics next week. I'm like, really? Well, Dr. So-and-so isn't going to dig that back out. So you're going to stay on it for life. But I do know several colleagues, and in many published series that'll say that they were on it for, 1 month or for 3 months. And I think realistically, the idea of sort of suppressive, that those 30 bacteria that are still there just never get to 60 and to 90, just makes me feel good. But some ID people say they agree and they say for life, but there's a lot of them that'll say 6 weeks or 6 months. The interesting ones are the ones like this patient I have with brucellosis and another patient that I had with Mycobacterium. Obviously those are very indolent bacteria that are hard to kill and hard to diagnose, and those we treated them for a year with specific like full dose therapy, which was kind of interesting. But yeah, anyway, a lot of times we don't get a diagnosis. It's very common that you'll have fevers and chills and all this stuff, and you don't get a diagnosis. And in retrospect, I wonder if there's more of this stuff. This case in brucellosis, we have 2 at Emory. One is mine and one is somebody else's. I actually don't know who the other case is, but our ID folk said they had it. And I looked in the literature, and in the United States, this would be the only case of brucellosis aortic infection. There's a bunch of them from Saudi Arabia and the Middle East, multiple brucellosis, which, if you remember, is from sort of livestock related. And this particular patient of mine, he would go hog hunting. So the best we can come up with is that he somehow contracted it there.
Yes, because that is true that, we have a lot of sort of fevers and white blood cell counts that are moderately elevated, and you never know
right.
what the organism is. So it sounds like you go for rifampin because that's what's been done.
It's been studied the longest. There are some other publications with clarithromycin. There's a couple other antibiotics that they're not coming to me right now, but by far, in general, it'll cover most gram positives. And if you look at that list, strep and staph, most of them are sensitive to rifampin. Salmonella can be resistant to rifampin, so it isn't your best option for salmonella. But yeah, rifampin is sort of the most commonly used antibiotic. Gentamicin is another one, the risk of renal failure.
Any other questions or comments? Okay, well, I'll go ahead and close Grand Rounds then. Thank you again. That was great. We really appreciate you doing this for us this morning.
You're most welcome. Thank you for the invitation.
The preceding program is copyrighted by Emory University.